Welcome everyone to BTSS second part of our series on side effects and brain injuries resulting from brain tumors. In November last year, we talked about the common treatments of brain tumors and how they could lead to possible side effects and brain injuries. Now, resulting from any possible side effects and brain injuries, of course, patients and caregivers now grapple with the next challenge of dealing with the side effects and brain injuries. And that's why we have organized this topic for today's discussion. So I warmly welcome all of you, our speakers. Thank you for making time to be here. And also all of you who are attending this session today. So I would like to explain the guidelines to today's forums. Firstly, as we all know, the speakers and David and myself will have our video on, and at the same time, all of us will be mute except for the person who is speaking. So participants, thank you so much for keeping your videos off and on mute as well. I'd like you to know that we are interested to hear your questions or your concerns. So you do know that Zoom has a chat function. So if you could put in your questions into the chat anytime you want, and we will address it in due course. So this e-forum is recorded and eventually will be shared on the BTSS social media. So if you are uncomfortable sharing personal details, then I would ask you to be more generic in your questioning, for example. And finally, we are doing this to empower you through general information. So pertaining to your specific conditions, we want you to know that this cannot be a consultation for your specific conditions. And we encourage you to seek advice on your particular situation. So this is it, side effects and brain injuries, part 2. So joining us for part 2 will be speakers who are familiar with both children as well as adult situations with brain injuries and side effects. And I would like to introduce to you Dr. Ng Zhiming. She's a senior consultant overseeing all the neuro-rehabilitation in the Department of Pediatrics in KKH. Again, I note that there are no parents in our midst so far, but I believe that Zhiming would still have the knowledge to be able to address broad questions regarding neuro-rehabilitation. And we also have Miss Deirdre Tay. She has worked in Singapore General Hospital for 15, coming to 16 years already. And she brings with her vast experience in speech therapy. She does all kinds of speech therapy, for conditions like strokes, and then and right now she's also helping brain tumor patients. So the agenda for today starts with Ms. Deirdre Tay, and she would be making a presentation. And as she makes the presentation, again, please feel free to share whatever questions that you may have in the chat. And when she's finished her part, then we will have Dr. Ng Zhiming sharing her presentation and also addressing your questions. And at the end of it all, we would have a panel discussion, and Dr. David Low would also be involved in it as well. So with that, okay, so I'd like everyone to join me to welcome Deirdre. Over to you.
Thank you very much. I was just toggling the screen, so apologies for that weird, awkward silence. I'm going to thank David and Melissa for inviting me to speak to all of you today. And thank you for your time. As I kind of share with you a little of what I know about communication challenges with brain injury. So as some of you are patients yourself, you're quite aware that brain tumor is a type of brain injury. And brain injuries are essentially, some types include strokes, traumatic brain injury, say from a car accident, and even inflammation of the brain, which is encephalitis. So, how does the brain affect communication? Many of us take it for granted, the ability to communicate, basically, since we have been developing this skill from the time that we are born. However, the ability to communicate well requires extremely complex skills. And as you can see in this diagram, it actually shows you the different parts of the brain that are involved for different purposes of communication. Therefore, communication for people with brain injury can be very common, and many people with brain injury may experience more than one form of communication difficulty after their brain injury. This depends on the area of the brain that is affected, as well as the severity of the injury. So what this diagram shows us is the cortex, which essentially is the outer part of the brain. The cortex is responsible for our thinking or cognitive skills, functions such as understanding and expressing of language, reading and spelling, planning and organizing, attention, as well as social skills are very important for communication. Therefore, injury, or in some cases, the presence of a tumor in any of these areas can impair someone's ability to communicate. I'm just going to ask, would you like me to make this enlarged?
Yes,
Is it
I
better
think
for
it'll be
everyone?
better. Yes, it's much better.
Okay.
Thank you.
So what we know is that communication involves the act of transferring information from one person to another, or sometimes to a group of other persons. So communication essentially involves at least one sender, a message, and a recipient. Sounds very simple, but actually communication is a very complex subject. So what we have, and I think when I speak to most lay people about communication, a lot of them will say, oh, it's just about talking, isn't it? But actually communication encompasses a lot more than just talking. What you require is adequate speech movements so that you can articulate and that you can voice. You need to also have adequate language abilities so that you can comprehend the message and you can also then opinionate your message. And a lot of times it is also about understanding non-verbal language, social rules, when communication breakdowns happen and how to correct them. So as you kind of see, what we have here is when there is a problem with the physical movement, you may experience difficulties in moving speech muscles as well, and that affects the way you actually articulate, the way you voice. And the terms that you may have heard medical professionals use would be dysarthria. To a lay person, we might say, oh, you sound slurred, or dysphonia, which is a problem with voicing. For some other patients with brain injuries, they may have difficulties with the language components. And what it means is that you may have difficulty with comprehending words, and you may have difficulty using words in order to construct a sentence. Some people may also have cognitive difficulties, which essentially is a set of thinking skills, and it controls things like attention and concentration, memory, the way we reason and problem solve, how fast we are able to process information, and also whether we have insight into our difficulties. So when people have cognitive difficulties, they may also present with difficulty in their interaction, which essentially affects or is affected by their cognitive communication difficulties. Now, I think nothing says more than a video to explain what aphasia is. So earlier on, I explained that aphasia is a type of language difficulty as a result of a brain injury. So this website is TED-Ed, and some of you may be familiar with the TED series of talks. And I'm just going to let this video kind of explain to you what aphasia is about. So let me change over to the website. And do let me know if you can't hear the sound.
Language is an essential we often take for granted. With it, we can communicate our thoughts and feelings, lose ourselves in novels, send text messages, and greet friends. It's hard to imagine being unable to turn thoughts into words. But if the delicate web of language networks in your brain became disrupted by stroke, illness, or trauma, you could find yourself truly at a loss for words. This disorder, called aphasia, can impair all aspects of communication. People who have aphasia remain as intelligent as ever. They know what they want to say, but can't always get their words to come out correctly. They may unintentionally use substitutions called paraphasias, switching related words like saying dog for cat, or words that sound similar, such as house for horse. Sometimes their words may even be unrecognizable. There are several types of aphasia, grouped into two categories: fluent or receptive aphasia, and non-fluent or expressive aphasia. People with fluent aphasia may have normal vocal inflection, but use words that lack meaning. They have difficulty comprehending the speech of others and are frequently unable to recognize their own speech errors. People with non-fluent aphasia, on the other hand, may have good comprehension, but will experience long hesitations between words and make grammatical errors. We all have that tip-of-the-tongue feeling from time to time when we can't think of a word. But having aphasia can make it hard to name simple everyday objects. Even reading and writing can be difficult and frustrating. So how does this language loss happen? The human brain has two hemispheres. In most people, the left hemisphere governs language. We know this because in 1861, the physician Paul Broca studied a patient who lost the ability to use all but a single word, tan. During a postmortem study of that patient's brain, Broca discovered a large lesion in the left hemisphere, now known as Broca's area. Scientists today believe that Broca's area is responsible in part for naming objects and coordinating the muscles involved in speech. Behind Broca's area is Wernicke's area, near the auditory cortex. That's where the brain attaches meaning to speech sounds. Damage to Wernicke's area impairs the brain's ability to comprehend language. Aphasia is caused by injury to one or both of these specialized language areas. Fortunately, there are other areas of the brain which support these language centers and can assist with communication. Even brain areas that control movement are connected to language. fMRI studies found that when we hear action words like run or dance, parts of the brain responsible for movement light up, as if the body was actually running or dancing. Our other hemisphere contributes to language too, enhancing the rhythm and intonation of our speech. These non-language areas sometimes assist people with aphasia when communication is difficult. So how common is aphasia? Approximately 1 million people in the US alone have it, with an estimated 80,000 new cases per year. About 1/3 of stroke survivors suffer from aphasia, making it more prevalent than Parkinson's disease or multiple sclerosis, yet less widely known. There is one rare form of aphasia called primary progressive aphasia, or PPA, which is not caused by stroke or brain injury, but is actually a form of dementia in which language loss is the first symptom. The goal in treating PPA is to maintain language function for as long as possible, before other symptoms of dementia eventually occur. However, when aphasia is acquired from a stroke or brain trauma, language improvement may be achieved through speech therapy. Our brain's ability to repair itself, known as brain plasticity, permits areas surrounding a brain lesion to take over some functions during the recovery process. Scientists have been conducting experiments using new forms of technology, which they believe may encourage brain plasticity in people with aphasia. Meanwhile, many people with aphasia remain isolated, afraid that others won't understand them or give them extra time to speak. By offering them the time and flexibility to communicate in whatever way they can, you can help open the door to language again, moving beyond the limitations of aphasia.
So let us bring back to the presentation. I think they've actually summarized the key points about aphasia very well. And I think the ending part really resonates with a lot of the patients that I work with who have aphasia or who have different types of other communication disorders. So it is very isolating when you are not able to make your thoughts known, when you're not able to participate in social communication like you used to. And I think we have a mix of both caregivers as well as patients yourself here. And what I've done is actually kind of constructed a little bit of a tip sheet. By no means is this comprehensive or exhaustive in that sense. It is a little bit of a subset, I think, of many things that we can do. But how do we help someone who seems to have difficulties with language comprehension? As a caregiver, it's important that you get their attention before speaking. What you want to do is make sure that your language is simple and slow. But if you're talking to an adult, make sure that you don't simplify your speech and talk to that person as if the person's a child. You may need to repeat if someone needs the information to be resaid so that they can understand it better. Sometimes it's also quite useful to be able to write down keywords so it prompts the person to what you're saying. As a person with aphasia or a person with language comprehension problems, don't be shy. Ask for repetition if you need it. You may also ask the person that is speaking to you to help you write down those keywords. You may also then tell people what's your preferred ways of communication. So for example, if showing you pictures help you to kind of zone into the key topic, do that. If you need them to speak slower, tell them that as well. Now, if you happen to be communicating with someone who has difficulties expressing themselves, okay, what the listener can do is pay close attention. When I say reduce distractions, it means reduce the distractions that might take you away from the conversation that you're having with the person. And if you don't understand, do not pretend to understand, okay? Feedback what you've understood, and therefore, if there needs to be clarifications, the person can make the necessary adjustment. What you can also do is encourage nonverbal communication. Some patients who have difficulty with expressing words may actually be stronger in terms of their writing. They may also have certain gestures that will help you to understand if they are saying yes, no, or other means, okay? For the person who has difficulty with expressing them yourselves, what we need you to do is to relax as much as you can and do not rush your communication. If you know that you have other methods of nonverbal communication which are helpful, then please use them, such as writing or gestures. It is very easy to be discouraged because communication is so difficult, but do continue to stay positive and be focused on your minor successes. Now, when you meet somebody who perhaps have difficulties with interacting well because of difficulties in cognitive skills, what can really help is if you reduce the environmental distractions. Routines or a predictable plan usually help someone who has difficulty with managing the stress of unknown areas. It is also much easier for them to process information if you are able to break down a complex activity or complex instructions into smaller steps. Always give them time to process, because things which are happening in a hurry, when it's very fast, may actually make it more overwhelming for a person with cognitive difficulties. Now, if you yourself experience difficulty with cognition, what can really help is if you anticipate your journey, anticipate your schedule, and plan ahead. So avoid rushing so that you have time to do and execute what you need to. Try to do one thing at a time so you don't end up overwhelming yourself. And if you have difficulties with remembering things, then use reminder systems that work for you to help yourself. So previously, it might be pen and paper. people keep paper diaries. I think these days it might be more safe to say that you might be using your phone a lot to keep yourself on track. Again, don't be shy to ask for repetition of information you need, or even to ask for information in written form. So I think that's all I have to share in terms of the short presentation today, but I've compiled some resources that I thought may be helpful. If you or someone that you know do require help with communication assessment and communication therapy, all the major hospitals in Singapore do have speech therapy departments, and therefore you may be able to contact them for a referral and an assessment appointment. There is a website that I've also referenced a lot with my own patients, which is Headway. It's a brain injury patient support group that is based in the UK. They have excellent resources when it comes to easy to understand information about brain injury and the effects that it has on different, or the different effects that brain injury brings about. And then locally, for people with aphasia, we want to be able to encourage them to come together so that they get to practice their communication skills, have a means of being able to also socialize with other people who have similar communication difficulties. You will be able to actually find them on Facebook or Instagram, and it's called the Chit Chat Cafe. Okay, they meet once a month. I think it's the last Saturday, if I'm not wrong. Yeah.
Okay.
And that's all for me.
All right. Thank you, Deirdre. So far, there are no questions in the chat. All right. But I think all of us want to give you a hand. Thank you so much. I learned so much about the brocas and what's that? The area.
Area.
Winika, is it?
Wernicke's.
Wernicke's. Okay. Yes. All right. Not so bad. Am I having aphasia? I hope not. All right. So now, are there questions? Could you perhaps, I'm going to give you this time, anything related to Deirdre's talk about speech and speech conditions? You could show your video and ask your question. Okay, I think so far no one, but in case you need some time to string your questions together, I'm going to do a short poll. Okay, some people just join us, so welcome to you if you have just joined us. So I'm just going to do a quick poll anyway, as a break before we moved into this. I'm having like a problem with your poll session is inactive. Well, I don't know. It seems like it's currently inactive, so I'm unable to activate it. My apologies. So in any case, then
I somehow am able to launch the poll from my side.
Oh, okay. All right. So maybe what I should do is I should withdraw. Okay, and let's see whether I can launch the poll. No, I can't. So maybe you would launch the poll for me.
I think when you just did that, the poll went away.
Oh, David, are you accessing the poll?
Nope, I don't see it.
Oh, right. It came out. It just.
Oh yes, it's come up.
You've managed to launch it, I think.
David's launched it.
No, I think you managed to, Melissa.
Sorry, I did it. It popped out, so I just helped you launch.
All right. So everyone, you will be able to see the poll. Okay, so I think the first question relates to what kind. There are two questions in the poll. So Tsuming, I cannot see the poll at all because I am a host. So can you read the first question?
Yeah. Okay, number one question. Please select the side effects that are relevant to you. Multiple choice.
Right. So
number
you can
one,
select anyone that's relevant to you. All right.
Number two, swallowing and eating. Number three, cognitive.
Yeah.
Memory, learning, processing.
Yeah.
Number four, vision. Then hearing, mobility. In terms of walking, running, use of arms and hands. Then sleep, then mood, then aches and pain, then others.
Yeah, I think the others should be seizures. I forgot to add that. So the others should be seizure. So if you have seizures, you put it under others. So when you see like about 5 people or so, you see that there is no more responses coming in to me. Could you please just launch the results?
Can the attendees see the questions? So far, 0% has voted.
Can see the poll but can't submit.
Oh, okay. I have one person that has submitted.
Yeah. The submit button is right at the end of the poll.
2.
Okay.
2 out of 9.
We got to minus the few of us.
Oh.
Yeah. Vivian, I'm so sorry. I don't know how to address this grayed out thing.
Vivian, this is Deirdre here. I think what you'll have to do is pick an option for both questions, and then the gray button will turn blue.
Yeah, that means you have to do both questions, not one question at a time, right?
Yes.
Okay, thank you, Lily. The second question, of course, relates to, the challenges you face with the side effects. It could be anything from the inconvenience or the frustration of seeing very little results and things like that, you see. So, so you have to do both questions. So indicate that. I think it's good feedback for us to know the challenges with regards to your rehabilitation issues. So, Ziming?
Okay, we have 7 out of 9 already.
Okay,
Is
I
that
think we
enough?
can, yes, we can see.
Okay, so our end poll.
Yes.
Share results.
Yes.
Can you see the results?
Interestingly, I cannot see, but never mind. Tell me how's the result.
1 person voted for swallowing, 3 for cognitive, 1 for vision. Hearing has the most, 57%.
Okay, yeah, I think we just zoom on the top 3 for each question. So for the first question, the most common side effects that our participants in this chat face would be hearing.
And the seizures, others.
Seizures, okay. And any more? That's all.
These are the 2 most common ones, then followed by cognitive.
All right, okay. And then speech, we only have 1 person?
Yeah, speech is interestingly 0.
0, okay.
Swallowing
great.
and eating is 1.
All right. How about the one about the challenges they face with rehab? That would be an interesting one.
Yeah, number 2, yeah. So I think
Highest.
most people voted for anxious to know whether it will get better.
Yeah. And then
yeah, some of them worried about whether it will affect employment, whether it will affect school. And the condition has not improved despite therapy. Do not know what to do if the condition does not improve, and it is financially burdensome.
Okay, great. I think, having heard their concerns, maybe this is a good time, to address the concerns that our participants are voicing in this poll. So, should we just talk about it? Like, I can understand because I was a patient myself and I couldn't close one eye. So you can imagine it was very scary and had double vision and things like that. So I can understand how they feel. So the frustration and the anxiety of knowing whether or not it will get better. How do we know? I mean, how long before we know that something will not get better? And what do we do if it really doesn't get better and it's affecting our life, our work in a serious way? Okay, so this is open to Deirdre, Ziming, as well as David. Please.
I suppose I think some of it I may be like touching on later.
Okay.
Yeah. But it's
So
a very
we will leave the parts that you will touch on later. Okay. Yeah.
I don't know, maybe Deirdre, you can share first.
I think from my experience working with, I work with adults, so I can't say very much for young children, perhaps in the same condition. But I think one of the top worries with adults, it's always, especially working age adults, is do I have the ability to still resume the work, the role that I play? Yeah. And it's a very real worry, especially when the brain injury affects a lot of the cognitive skills. So everyone requires perhaps a different variation of cognitive skills for the work that they perform. And even for the life roles they play. So, you know, if someone's a parent, someone's a husband or a wife to a spouse, they all require, you know, that in order to perform their life and their occupational roles well. I think this is where there's a little bit of perhaps faith that comes into the whole journey. And as I say to my patients, it's a journey that we're going to walk together. You, me, the doctors, the other rehab professionals that are involved in the recovery process. For some people, it can be quite heartening because we're talking about progress that happens in a matter of months. For some people, it might take years. And obviously, the more deficits or the more complications there are in the original medical condition, it can make the journey obviously a lot more arduous. So, but we've definitely seen success, I think, with patients who are keeping themselves motivated when there are family members that are, you know, constantly there with support. And I think that's how we kind of work together to a level that is good for everyone.
Thank you for that. So, David, you want to say anything?
Well, if we are addressing the top three, I guess for seizures, I think most of the time it will be related to medical treatment with the drugs. Therefore, optimizing the medications with the treating physician. Granted, there are side effects with the medication, so sometimes they have to be tweaked and adjusted. In terms of hearing, I guess depending on the condition, sometimes that may be permanent. Of course, hopefully there's the use of hearing on the opposite ear. But I guess there would be certain, depending on the severity, there would be certain aids that ENT surgeons may be able to offer to help with that, and some adjustments. And lastly, for cognitive issues, I guess there is a role sometimes for the neuropsychologists who may be involved in performing certain assessments to actually objectively quantify the deficits. They may also be able to offer sort of various strategies to help them cope. I mean, for children, you know, and parents who look after them, or the adults, ways to help with remembering things or managing things in their day-to-day lives. So those are things that can help with these deficits. Yeah.
Okay, thank you. I think, you know, with this short time of interaction, we have gathered enough so-called questions and an indication of the interest level for Ziming. You know, you would be the next person, and now that you know what they are interested in, perhaps that would be a good way to guide you in sharing with us. So over to you now, okay, for your presentation.
All right, I'll try my best.
Don't worry, I'm sure you'll be fine. Okay.
Okay, let me share screen first. Okay. Right. Okay. Yeah. Okay. So this is I guess the part part two of this BTSS talks on side effects and brain injuries. And so we were talking about, side effects of treatment for brain tumor and then an injury to the brain as a result of that. So I'm actually very delighted to share with you, from a pediatric neuro-rehab point of view, how we can actually better manage some of these effects. And to really illustrate this point, I like to zoom into one of a very, very common phenomenon that we see after surgery for brain tumor in childhood, which is posterior fossa syndrome. I'm not sure it was covered, if it was covered in the previous talks, but generally in childhood tumors, medulloblastoma is one of the commonest, and then this happens a lot, not really a lot, but in a certain percentage of the patients after surgery, and then most of the time neuro-rehab would be involved if the child has got a posterior fossa syndrome. So this is the outline of my talk. So a little bit of introduction about myself and my team. Then we will zoom into what posterior fossa syndrome is about in terms of where, who, why, when, what, and then so how. So this is us. We call ourselves PINS, or Pediatric Integrated Neuro-Rehabilitation Service. It's a big team, and these are the common medical conditions that we cover. So namely two main categories, right? Acquired brain and or spinal cord injury, as well as long-term neurological conditions. So under acquired brain injury, other than stroke and encephalitis that Deirdre mentioned earlier on, we also have brain tumor. Okay, so let's talk about posterior fossa syndrome. To understand what posterior fossa syndrome is about, then we have to first know where posterior fossa is. So basically it's the back of the brain, right? And the structures at the back of the brain includes the cerebellum, pons, and medulla. So pons and medulla forms part of the brain stem and then your cerebellum. So here I have like sort of the basic functions of each part of the brain. So if we look here, cerebellum, the basic function is balance and coordination. And then for brainstem, the basic function is breathing, the heart rate, the alertness, temperature, all that is like sort of the automatic function of the human. Okay, so you can imagine, okay, if there is a tumor that is in this area, so some of the automatic or some of the basic functions can be affected. But what is so interesting about cerebellum also, it also has got some of the signals or neural pathways with the rest of the brain. So the cerebellum actually sends signals from this to, let's say, to the frontal lobe over here that is in charge of movement, speech, behavior. Okay. And then it also has got connections to temporal lobe that has got to do with memory, processing speed, and like what Deirdre pointed out just now, understanding language. You also have connections to the parietal lobe that will be in charge of integrating information from all the senses. And then deeper inside, there is also connections with the limbic regions, which control emotions. Okay, so this is just a rough idea on all the different brain functions and how how important cerebellum is in the posterior fossa. So who are the ones who actually get posterior fossa syndrome? So it is estimated that posterior fossa syndrome can happen in up to 30% of the children who may have a posterior fossa tumor. So again, like what I said, the commonest will be medulloblastoma. Okay, other tumors can also include ependymoma, astrocytoma. So why is it that posterior fossa syndrome happens? The tumor, when it first happens, I'm not, so this is really more into the children per se. So it's like usually it's in homeostasis. The tumor can slowly grow, and then finally to a certain threshold point, then it presents with certain symptoms. For example, they can present with headache, vomiting, or imbalance. Okay, and and then after that, when they have a brain scan, then they realize that there's a brain tumor at the back of the brain. things may not be so bad, but after surgery, things can get worse. Why is that so? So it is postulated that most likely it could be a disruption of these, all these pathways and signals that that is from the cerebellum to the rest of the brain. And as a result of that, posterior fossa syndrome happens. I'll go into a little bit more detail on exactly what posterior fossa syndrome is later on. But generally, currently, evidence shows that the bigger the brain tumor and the more midline location, if it involves the brain stem, if there's a lot of edema around the surgical site, a more extensive kind of surgery, if there's hydrocephalus, there is a higher risk of posterior fossa syndrome. Okay, so when does posterior fossa syndrome happen? So it's actually quite scary, before the surgery, the child is okay, not too bad, just a little bit of headache, vomiting. Then posterior fossa syndrome suddenly set in after the treatment. So this is a study done about 10 years ago in US, looking at 63 children with medulloblastoma. And it is found that about 30% has got posterior fossa syndrome. Some of them have had the symptoms immediately after operation. Some of them 1 to 2 days after operation. Some of them 2 to 4 days after operation. And that it is noted no patient developed posterior fossa syndrome 4 days after surgery. So this is roughly the timeline when the symptoms set in. So now, what exactly is posterior fossa syndrome? When we talk about syndrome, it's like a very vague thing, right? It's a constellation of symptoms. So in this case, it's a constellation of some very distressing symptoms in 4 main categories. So number 1, speech and communication. Okay. Number 2, motor control. Number 3, emotion and behavior. Number 4, learning and understanding. So I guess all these sort of covers are covered under the poll, right, that Melissa gave just now. And in terms of speech and communication, Deirdre also gave us a very good overview already. So sometimes it can be as extreme as complete loss of speech. So they become mute. So that's why sometimes people coin this phenomenon as cerebellar mutism. So even though they actually know exactly what's going on around them, they can't produce speech anymore. And in some cases, even if they can produce speech, there is generally decreased speech production. That means they don't say as much. Dysarthria, which was covered earlier on, they become very slurred, unclear, or there's just change in the speech quality, or difference in terms of like the melody. They become more robotic, more difficult to initiate speech. So there can be a big spectrum of how speech can be affected. Next is motor control. So like we know the cerebellum is in charge of balance and coordination. Then yes, the gait can become unsteady. They can even forget how to walk. The tone can become very low. Emotion and behavior. Just now we talked about how the cerebellum actually sort of connects the whole brain together. And then you can imagine now that, we can still understand what is happening, but things are a little bit disruptive, very, very disorganized. And then from the patient's point of view, they can feel very frustrated, very irritable, inconsolable, in distress, a lot of emotional lability and behavioral change. Okay. And then also because it connects with either other cognitive functions, so it can also affect learning and understanding, which is one big area that I think the audience is concerned about today. So, and then there is also another question about how long, right? So after having such an effect from treatment, how long will it last? So for this case in posterior fossa syndrome, it is heartening to know that majority of the children can make significant improvements. So first of all, the symptoms can vary, the spectrum of severity can vary. Some very, very mild, some can be very, very severe. And then also the timeline as to recovery is also very variable. So some, because of mild symptoms, can recover quite fast. Some, because of quite severe symptoms, can take a longer time to recover. Or in this case, I would say make significant improvement. And then actually the audience is probably right as well, so sometimes we don't know how long this will take and whether or not there is actually a chance of full recovery. The truth is, say for posterior fossa syndrome, the extent of long-term difficulty sometimes may not be evident in the initial phase, and they only become apparent later on when the child or the patient returns to home, returns to education, and then the patient is suddenly faced with even more difficulties when they are in a home environment, as well as in the workforce or in education in the school environment, okay, which can be very, very distressing. Okay. So how? I guess, like Dr. David talked about, maybe touched upon it earlier on. So the in treatment of brain tumor per se is mostly about survivorship, right? We want to take out or resect the tumor as much as possible so that there is very, very little or very, very minimal residual disease. So almost it is it's impossible to sort of prevent it. But then the surgeons can try as much as possible to plan the surgery such that try to limit the extent of surgery as much as survivorship is concerned. But then after that happens, so what we can do is try to recognize the effect early. So, and even though, and also to know that, okay, there may be short-term effects, there may be long-term effects, and therefore we need to measure them and really monitor for these effects. And then once the diagnosis is made, early neuro-rehabilitation should be initiated. So how we do it is by a multidisciplinary approach. And so right now, I'd like to share with you a short video clip. Sorry, let me just share again. Sorry, just I think I opened multiple.
Okay, great. Looks like it's coming up.
Okay, can already?
Yes, I can see it. Is there a volume?
Is it okay?
There is no
There's no
sound.
audio? There's no
Yeah,
sound?
I don't hear anything so far.
Wondering whether you need to also share sound. There's a option
Okay, hang
for
on,
share the computer sound. When you share, it's on the left bottom.
Sorry, can you give me the instructions again? How to share sound?
Okay, when you share the screen, you notice that there will also be an option at the left bottom to share computer sound. So you click that.
Okay. Okay, I got it.
All right. Okay.
Where's the remote? Where's the remote? Where's the remote? Watch.
The Paediatric Integrated Neuro-rehabilitation Service is supported by a multidisciplinary team comprising of doctors, nurses, and allied health professionals. The service provides coordinated care to support pediatric patients with acquired brain injury and long-term neurological conditions. The Allied Health team is a vital part of PINS, comprising of physiotherapists, occupational therapists, speech therapists, music therapists, medical social workers, neuropsychologists, dietitians, pharmacists, and orthotists. The road to recovery is long. Children with long-term neurological conditions will require continual support in the community. PINS aims to build a strong community network to enable seamless care transitions and promote reintegration into home, school, and the community.
All right. So this was just an overview of how we could use a multidisciplinary approach, okay, to deal with patients after a brain injury. So like you see just now, so in terms of the medical team, we sort of work together. So because a lot of times, even after surgery, while they are actually sort of rehabilitating from the brain injury, there could still be a lot of treatment that is going on. For example, chemotherapy, radiation. So we sort of still have to work with the medical team and to try and help the patient in terms of trying to recover from the lost skills, and then at the same time try to prevent deconditioning. So at the same time, dabble with even more side effects of treatment. Then after that, also we sort of saw in the video that we have physiotherapy to help with motor mobility, balancing and gait. Occupational therapies mainly in upper limb skills as well as activities of daily living. So in terms of cognition, a lot of times, is how the child actually or the patient performs in a social setting. So in this case, the OT will actually be helping a lot in terms of the cognitive rehabilitation. Just now you have heard about Deidre, how speech and language therapies can actually help in terms of speech and communication. Orthotist, sometimes a child can actually not, be very, very weak to walk, not have the tone or, difficulty in balancing and coordinating, and sometimes braces can be helpful. So we also talk about mood and behavior. So music, art, and play therapy can also help to support the child together with the medical social worker. A lot of the neuro cognitive effects, right? We have to involve the neuropsychologist. So first, the neuropsychologist will have to do the assessment and then sort of follow the patient up and to see how the child has actually progressed and what kind of intervention or accommodation can be given. Nowadays, we also even try to do it at baseline. That means before any radiation happens, we also perform the neuropsychological assessment, and then after the treatment, perform another one to see how much of the neurocognitive effect has actually happened after treatment. Dietitian wise, also usually work with the speech therapists a lot in terms of nutrition when the child has got a problem with swallowing. Just now we also talked about seizures. So usually seizures, we will need medical treatment in terms of pharmacological intervention, and that's where the nurses and the pharmacists will come in to help the family. And also, it is not uncommon for us to use medications to control mood as well as behavior. So sometimes when these medications are used, the pharmacists also come in to see if they interact with any of the treatment that the child, the patient is still having, and then so as to optimize the dosage as well as the side effects. So rehabilitation continues actually even after discharge. It goes to even when the child or the patient goes back to home as well as community. So there is a need for continual assessment for medical needs, physical needs, psychosocial and emotional needs, as well as educational needs of the patient, even after discharge from the initial treatment of the brain tumor. Just now, I think there were people concerned about return to workforce, employment as well as education. So this is actually very, very important part of rehabilitation as well. So after the treatment, generally there will be a time where the child sort of get used to back to home first, right? Or the patient get used to back to home first, and then there will be a gradual return to school. And in pediatric per se, school is a very big social role for the child, right? So actually we are actually quite fortunate to have sort of like the interim, before the child goes back to school, there is actually PAL school in which the patient can actually sort of attend sort of a bit more truncated, school to sort of get used to the school kind of program, the syllabus, and then with a lot of accommodations and breaks in between so that they are not so easily fatigued. Because at the start, you can imagine it's actually very, very difficult to just go back to our educational system, especially because Singapore, it's actually quite demanding in terms of attention, memory, processing. So at the start, definitely they will not be able to go back in full force. So there's actually an interim. And then before they go back, even when they go back to school, there's a need to let the teachers know, what the child's condition is. And then so that they can understand their needs. Then finally, there's a lot of support that has to be given as well. So we usually will also refer the child to the community providers, sort of to help these children, whether they are back in mainstream school or sometimes they are no longer suitable for mainstream syllabus. So sometimes they may have to go to special schools. So these are the main kind of assessment of the educational needs. And then after that, what kind of interventions, what kind of accommodations that we can give to these patients. So in summary, it is essential to recognize posterior fossa syndrome in children post brain tumor surgery. And the posterior fossa syndrome has both short-term and long-term effects. So generally, we will adopt a multidisciplinary approach in neuro-rehabilitation to help support affected children and their families. Okay, thank you very much.
Okay, thank you, Ziming, for sharing such a comprehensive information about the multidisciplinary approach to the posterior fossa syndrome. And separately I received a chat from a parent who said that she really appreciated your sharing on it pertaining to her son, who is also a patient. Okay, so right now I would like questions from the rest of you pertaining to anything that Dr. Ng has shared. Or we can leave it to questions in general that you have for your own conditions. I know many of you come probably because you're anxious about your own conditions. So we need not have to talk about the pediatric side effects that Dr. Ng talked about. So anything, for example, we've got one from Tun Lee here. How long typically does post-op for the removal of brain tumor, brain swelling to take to resolve? Provided no recurrence, would we expect complete resolution? And would we expect recovery of lip strength to continue as the swelling resolves?
I guess David will be the best person to talk about how long does the post-op swelling happen. Yeah.
Yes. Let me just look at the question again. So essentially, in terms of post-op brain swelling, so this may happen to different degrees after surgery, depending on how complex it is, how long the surgery is, and the location of the tumor. If you have to go through, if the brain tumor is in a deep location and one has to go through long, deep surgical trajectory, then one might expect potentially more swelling to occur. But typically, I would say the swelling should resolve over the next 1-2 weeks if it was pretty severe. Swelling alone does not necessarily translate directly to recovery, although we certainly hope that after swelling resolves, the deficits would progressively improve. So to address the second part of the question about the recovery, independently from brain swelling, of course, it would depend on whether prior to surgery was there already any weakness or any deficits resulted from the tumor itself causing damage to the neurons. If not, if it was because of irritation from surgery, then again, on a case-by-case basis, it varies. What I usually explain to families then is, really sometimes it's hard to predict, and what we can do is just make sure that the environment for recovery and healing is as best as possible. So making sure from a physical standpoint, the patient receives the necessary therapy for training, and of course, other aspects, psychosocial aspects of support to help the patient. That's it.
Yeah, thanks, David. So maybe I'll just add on to that. Yeah, you're right. Sometimes, so I guess to Tun Lee, the post-op side effects per se, right, is not just limited to the swelling itself. If it's the brain swelling, then maybe we can talk about it in terms of irritation to the brain cells. Then in which, after the swelling, settles, the brain cells should go back to its normal function. However, it may not just be that simple. So in the course of the surgery, or in the course of treatment, or simply from the tumor itself, there can be brain cell that is actually affected. That means, actually injured, okay, per se. So when the brain cell is injured, unfortunately, then that particular brain cell cannot sort of regenerate. So unlike skin or any organs as part of the body, right? Most of our cells can actually regenerate. Let's say if you have a cut, right, and then there's a wound, and then after that the scar happens. After that regenerates, the scar disappears. But for brain cells per se, it's very, very different. It doesn't really regenerate, but there's such a thing called neuroplasticity. So other brain cells that are not affected can actually take over the function of the brain cells that has been injured. So that is why early rehabilitation does help, or intensive rehabilitation does help, because then you sort of can train the other brain cells to take over the function that has been lost. So that is just in very, very simple terms. And then just now we also talk about the pathways that have been affected. So pathways is like expressways, right? So we connect the town to let's say Yishun, Woodlands, via the CTE. Okay, but it will be very, very simple if we could just, there's a block to the CTE, then you cannot connect to that part of the country anymore. But then again, in the brain, it is much more complex than that. So even if you try to repair the expressway, this expressway may not be the same as before. So that's why I think a lot of the audience right here is probably struggling with, having some residual effects, and then it's still taking a long time, and I don't really see much improvement, because what you're feeling is probably, the brain has been injured. It's almost like a broken brain, right? And the brain is not the same as before again, no matter how long and how much I try to do. But a good news is that neuroplasticity can happen even when you're very, very old. That means it's just people used to say that neuroplasticity is the best for children. Okay, but the truth is, children also have their set of problems, because it's a young brain, it's an immature brain. The expressways haven't been formed in the first place. There was no expressway, or very, very rudimentary kind of roads in the first place. But for adults, that the expressways and the signals and the pathways have actually been well formed, and then there is a disruption. So neuroplasticity, no matter how old you are, can still continue to happen. Okay, so that's why it takes time, and that's why a good social support, having faith, having that positive attitude, having the optimism will definitely help. Sometimes it's just that, unfortunately, even from my point of view, I can't really tell my patient how long this will take. Yeah.
Yeah, okay. Thank you for that, Tumour. And we have a question from a parent asking about her son's condition. He has a VP shunt in his brain, and at the moment there are no side effects noted at all. So do they need to do anything at all, or just leave it?
David?
Yeah, I guess I'll take that. No, so once a shunt is put in, I presume it was from some time back. Obviously, in terms of follow-up, they're usually seen in the clinic once a year, or at least once every 2 years. Realistically, we don't know. We assume that the shunt is doing its job in draining fluid from the brain down to the abdominal cavity. But in reality, if for whatever reason the brain circulation, the fluid in the brain is doing its own job, then potentially the shunt is actually redundant. However, there's no way of actually testing that. So if it's, to put it simply, if it's not broken, then we just leave it alone. And as long as he's doing well and there are no concerns in terms of headaches, nausea, vomiting, sort of slowness in cognition and things like that, then we leave it alone. But if you're not sure, then certainly back to the doctor who put it in to get it checked out.
Yeah, according to that parent, it's more than 10 years ago. So
Yeah,
it's
so
like a maximum, you know, like, oh, at 10 years, you definitely must go and review.
actually it should be followed up regularly, because in
Like
rare
every
cases,
year, you would say, yeah.
yes, ideally, because we have certain cases where they have, lost follow-up for a long time and nothing may happen. But very rare cases, suddenly they present with symptoms because for whatever reason, the shunt may have broken or malfunction later on, many years later, and they may present then with symptoms of obstruction or shunt malfunction, which usually is again the headaches, nausea, vomiting. Yeah.
Okay, right, thanks. And Shirley has a question that there is a procedure to remove surgery scar in the brain to reduce or completely stop seizure. Do you know something like that?
Yeah, you
Not
have the right.
Not specifically. I mean, surgery itself, any brain surgery itself potentially causes disruption to the normal tissues and therefore results in some scarring and can already cause seizures in the long term, although it's rare. However, there are many reasons why one may have scarring in the brain from head injuries or abnormalities that you may be born with. So I think the question there may be a bit vague. I'm not sure about the specifics on what
So
is
I
the
think
yeah.
So, but I think in
Yes,
Texas Children's Hospital,
Mm.
I mean, basically I think what you're trying to say is basically epilepsy surgery.
I guess so, yeah.
It sounds like
correct.
it's an epilepsy surgery. Yeah.
Exactly. So epilepsy surgery is performed in KK Hospital. It's
Yes.
performed by David as well. Yeah. So basically it will involve trying to find out where the seizure is coming from. So
Correct.
if the seizure is coming from a particular part of the brain that is always sending signals, but then it is possible, after a very comprehensive assessment, to sort of remove that part of the brain to stop seizures. So this kind of procedure is available in Singapore, and then so it will actually involve a lot of assessment first to see whether or not the patient is suitable for this kind of procedure, and then after that procedure can be done, and then it may usually the aim is to completely remove or to stop the seizure, but sometimes there can be some some residual symptoms left behind, but usually it will mean that if the assessment was done correctly and comprehensively, it will mean that the seizure frequency should reduce. Yeah.
Yes.
Right.
Yeah. Thanks, Zimin. So what Zimin mentioned was essentially workup for the seizure focus, and we have to make sure that that is the exact focus that is causing the pattern of seizures that is being seen in the patient. So we don't want to do any unnecessary surgery. Yeah. So essentially, the neurologist should do the workup and make the assessment if something like that is possible.
Okay. Right. All right. We have only like 5 minutes left. So any more questions? Okay, it looks like more or less we have addressed all the concerns from the participants in today's session. So that's really great. And, could you